speaker. Dr. Carlos Jaén is the Dr. John M. Smith Endowed Professor and Chairman of the Department of Family and Community Medicine at the University of Texas Health Science Center at San Antonio. He is a family physician and health services researcher who is co-director of the Center for Research in Family Medicine and Primary Care. Over the last 15 years, he has collaborated as a co-investigator or consultant with Drs. Stang and Crabtree in multiple NIH-funded grants studying primary care practice. He was co-chair of the expert panel that in 2008 published the Public Health Service update of the Treating Tobacco Use and Dependence Clinical Practice Guidelines, and this year published the official translation of these guidelines in Spanish with the Spanish Society of Pulmonologists and Thoracic Surgeons. We are fortunate to have him speak to us today on best practices in smoking cessation for boomers.
Good morning. It's a pleasure to be here today. And in the spirit of promoting health, I'm going to ask you to stand up and stretch. So I was intrigued by the invitation to come over, and I'm delighted to be here. And one of the things that is always helpful to me is to know who's in my audience. So I'm going to ask, how many of you have direct patient care contact? Please raise your hand. Great. And how many of you live in communities that may do something about tobacco cessation? Actually, all of you do, because you have the opportunity. And if you live in San Antonio, you probably are aware that there are efforts now going on to do some policy implications and some changes in that direction. However, the focus of my talk today is going to be very specifically on the treatment of tobacco use and dependence, particularly as it applies to boomers. What I'd like to do is summarize the key recommendations that were updated in 2008, but then very specifically go about 10 recommendations that are practical. They are really designed as part of the process that the Robert Wood Johnson Foundation funded to adapt what is called consumer demand principles in smoking cessation for clinicians and health systems. So, but first let's talk about, so I want you to, at the end of this talk, be able to describe what did they mean by the baby boomer bulge for smoking? List the evidence-based treatments that are available for tobacco cessation, tobacco use and dependence, and then identify specifically how medication and counseling interventions affect people who have mental illness, and then maybe being able to implement at least 3 of the 10 clinician recommendations for increasing demand of tobacco use and dependent treatments. Do those sound like reasonable goals? Well, let's talk about that for a minute. So I see them in my practice, and part of what's happening is that the smoking rates are rising. They're not decreasing at the same level as it would be expected for people who were born after Second World War II or after the Second World War. They're not only smoking more cigarettes, but also smoking more pot. Many of the baby boomers are continuing to smoke marijuana, and if you don't ask, you won't know. But folks who are in the 50 to 60-year-olds are using marijuana, and they're using it because they have, and that's part of the codependence. I'm not going to be talking about marijuana use today, but I think that part of the issue with smoking in this age group is that the two are connected, or at least they are co-occurring. And I think it's very important for you, as you're in practice, to be aware of this notion. This is a graph that was recently published by the Gallup daily tracking. So if you look at that, this is by age, In the population, this is an ongoing survey of smoking rates, and those who are between, so in general, smoking goes up around the college age and then starts to go coming down. But as you can see here, there's actually a bulge. And this goes up to age 58, 60, and maybe 42. So this is really the boomer smoking rate, which is higher than had been in the past, where it usually was a transition as you get older. In part because smokers die early, so they get eliminated from the population, but also because smokers end up having chronic problems that then motivate them to stop smoking. I often use humor when I'm seeing patients. So when they're not ready to quit, I say, no problem, we'll wait until your first stroke or heart attack, and then you'll be very interested. Or when they cut off your leg, then you probably pay attention to this. Sometimes there are specific events that need to occur. So this is the clinical practice guideline update that we published in May of 2008. What I had highlighted here are sort of the 10 key points that I want to highlight, and then I'll take some more time to specifically tell you what is the evidence for the different components. So tobacco dependence is not a condition, it's a chronic disease. It's not unlike hypertension and diabetes. It's an indicator that someone is going to have major complications if not addressed. Just like we wouldn't think of having someone we have diagnosed as diabetic saying, oh, your sugar is high, exercise and eat right, and never address it again because that's their responsibility. I mean, I think that most of us will not feel comfortable saying that that's good practice in terms of diabetes care. The same needs to be true for tobacco. If someone is using tobacco, it's something that you need to address every time. It's a difficult, relapsing disease that needs to be addressed on an ongoing basis. And then in order to do that, we need to have systems in place to identify who the smokers are. Because some of the smokers are very obvious. They walk in, you don't need to ask them. I usually don't ask them, do you smoke? I just say, how much do you smoke? Because your nose will tell you that they smoke very heavily. But there are others that are very discreet. They use all kinds of colognes to hide it, or they do it in settings that are not particularly related to when they're coming to see you. So having a system in place in your office is very important to have it. And I think the other key point from the guideline is to make the point that treatments work for across multiple populations. So this notion that the treatments for tobacco cessation only work on the young, they don't work on women, or they work on men, they don't work with people with mental illness. You can make a long list, but the reality is that the treatments for tobacco cessation have the highest level of evidence in terms of evidence for effectiveness. Cholesterol, mammography even, do not have the level of evidence in terms of the return for the investment for tobacco cessation. The next point is the brief treatment is effective. So even treatments as short as 2 to 3 minutes that you are doing in the context of a clinical encounter can have an effectiveness. And it's usually a cumulative effect. So one of the things that I remember being in practice, and in the hallway there was a patient who was pointing to me. It was a patient of one of my partners, and he said, that's the guy. And I said, oh my gosh, what did I do wrong? He said, that's the guy who made me quit smoking. I didn't make him quit smoking, but when I saw him for an acute problem, in the context of, I used to talk to him about, do you really want to be carrying out an oxygen tank around? And apparently at that point, that was a tipping point for him to do it. So you never know when you're going to have an effect on a patient as you bring it up. And you don't have to get stuck there. Part of the issue sometimes is that I don't know about you, but I used to do this. I will go into a patient and I see that this is a smoker, and I'm going to say, okay, John, today's your day. I'm going to spend all my energy and time convincing you that you need to quit smoking today. And then I will use all this energy, John is not ready, and then I will feel defeated. And my next patient who is ready to quit smoking, I will not even mention it because I was so tired from that day. So I say, John, as your doctor, you need to quit. If you need a doctor to tell you you need to quit, I'm it. Are you ready to quit? No, I'm not. Okay, when you're ready, I'm here for you. What else can I do for you? But it's that being aware and being present in that sense, and being aware that brief treatments work. And counseling work, and more counseling is better than less counseling. But I think the important piece is that counseling alone is effective. Medications also work, and we need to consider them in every attempt because they really boost the chances that someone will be successful. And then this is a new finding from this version of the guidelines, is that medications plus counseling are better than either one alone. So whenever you can, doing that. Now, I know what some of you may be thinking, you may be rolling your eyes and said, easy for you to say, but how can you do counseling and medication in 15 minutes? Well, the counseling doesn't have to be provided by you. And I'm going to talk to you about telephone quit lines, which provide free, high-quality counseling services. They are available here in Texas. They are available nationwide. It's 1-800-QUIT-NOW. If you are a family physician, and you can actually write to the academy, they'll send you cards that are like credit cards that has a number, and they have in Spanish and in English, and you can pass them to your patients. They call, and it's not just reactive telephone quit lines, they actually have proactive, so they'll call the patient and follow up. I just recently saw a patient who had quit, he went back, and he was talking to me about why he went back and all that, and said, they keep calling me, and I'm gonna connect with them again when I try again. But so they actually build a relationship with your patients, and they do it. These are trained counselors. These are people who know what they're doing. And then another finding that we had from the guideline that is also an important step forward is that there is something we can do for people who are not ready to quit. And it's called motivational interviewing. The steps are in the guideline. The guideline is available from the AHRQ website. And it's really exploring with the patient, why do you want to continue to smoke? What are the benefits? Well, you want to protect your kids too. What are the discrepancies and other things? And I think there's evidence now that having that conversation increases the chances that person is going to try to quit in the future. And then treatments are clinically effective and cost effective. So we need to insist that health systems and health payers continue to pay for tobacco cessation. I don't know if you're aware, but recently there was an announcement that Medicare has been paying for tobacco cessation for up to, I think, 4 attempts in a year. But they have been very specific that you have to link it to a particular chronic disease. Well, the new healthcare law eliminates that requirement, and someone can be counseled just for having tobacco use disorder. And many of the commercial insurances are following suit. So let's talk about counseling efficacy. The level of evidence is an A, which means that we have multiple chronic randomized trials that support that evidence. And there are 2 parts of counseling that are especially effective. So the 2 parts that you want to emphasize when you're connecting to the patient or to working in your team in your office to make that work. It's practical counseling, which is essentially what to do on the day you quit, how you're going to address issues like going out or being exposed to alcohol or being for friends to work, or we have stressful situations, and also social support. To what extent are you engaging support either in your office or from your friends and coworkers in the smoking cessation attempt? And then for patients with mental illness, I think it's important to realize that counseling is critical to success, and more and longer sessions may be necessary, and they may need more time to prepare for quitting. And we should have some flexibility in terms of the quit dates and how we go forward. And including problem-solving skill training is also critical. Now, in terms of medications, There are three general classes of medications that are available for tobacco cessation as first-line therapy, and that's nicotine replacement, and that comes in multiple forms: the gum, the patch, our over-the-counter lozenge, nasal spray, inhaler. There's also a medication called varenicline, which is a partial nicotine receptor agonist. And I'm going to talk about combination of medications. Varenicline should not be combined with any of the other medications. And then there's also sustained release bupropion that is an important medication for smoking cessation. So if we looked at a meta-analysis, we had 83 randomized clinical trials, and we used both placebo and the patch as a reference group, and we looked at the relative efficacy. In other words, what works compared to another treatment, head-to-head. And as you can see here, the combination of the patch and a gum or spray increases significantly the chances compared to placebo from a 13% quit rate at 6 months to 36%, or increases it by almost 4 times. The patch plus bupropion, also known as Wellbutrin or Zyban, it increases it by 2.5%. Now, I didn't mention this, but there are also 2 second-line medications for tobacco cessation that are effective. One is nortriptyline, and the other one is clonidine. So if you have a reason to use clonidine or nortriptyline for people who have comorbidities, you may recognize that this is also a benefit. But the patch plus nortriptyline had this effect, patch plus inhaler, and then patch by the second generation antidepressant. Also, long-term medications. So in many cases, patients may need medications for a longer period of time. And here you can see the patch for 6 to 14 weeks, for more than 14 weeks, and you see an effect there, and the same with the gum compared to placebo. If we use the nicotine patch as a reference, so meaning that's the 1.0 there, varenicline at 2 milligrams a day is 1.6 times more likely to be effective. And so it's a combination of the patch for long-term plus the gum or spray. And the patch with bupropion also has an increased effect over just the patch alone. So in patients with mental illness, when it comes to medications, one of the things you have to be very aware of is the fact that most will need medication. And patients with bipolar disorder or eating disorder should not receive bupropion because it might make things worse. The patch is effective for those with schizophrenia. Varenicline's safety has not yet been established, so if you're going to use it in someone who has a stable chronic mental condition, you want to use it with very close monitoring to see what happens. And quitting, and this is a big point that I didn't realize at first, is that when you are, as many of you know, smoking accelerates the metabolic rate for many of the drugs that people they're taking for other reasons. So when they stop smoking, the metabolic rate changes. So the drugs accumulate and may have higher levels, and they might get into a point where they actually have complications. So it's very important to adjust medications, or at least be mindful of other medications that may need adjustment as people stop smoking. And it's also important to keep in mind that as people are trying to quit smoking, particularly if they have mental illness, they may be in a possibility of relapse as that's happening. Now, let's talk about medications and counseling. So if we compare medication plus counseling to medication alone, there is an effect that is about 40% higher when you put them together. And the same is true when you compare counseling to counseling plus medication. So and really, it's sort of like having someone with diabetes and choosing not to offer them physical activity and dietary interventions. I think those two go together is really the state of the art. And like I mentioned, the proactive quit lines are there. They are effective. They work in diverse populations, and they have broad reach. And the advantages of the quit lines are they are accessible. They appeal to those who are uncomfortable in group settings. It's convenient. They can do it from a cell phone. They can do it from a home phone. There's not the face-to-face embarrassment in terms of telling the truth and working on the component. Only takes about 30 seconds to refer someone to a quit line, and you're providing counseling in that context. And they are staffed by trained cessation experts who tailor the plan and advice for each caller. So they actually work hard to get them implemented. And calling a quit line can double a smoker's chance of successful quitting. This is the evidence here, and I think you have it in your package, so I won't belabor that. And the same is true. So this is true when you compare it to no counseling, and it's also true when you compare it with medication alone. So counseling in the quit lines work well. And like I mentioned before, motivational treatments work for smokers not ready to quit, and they are specific information in the guideline that you might want to use in terms of your interaction with patients. All right, so that's evidence-based medicine. That's the guidelines. That's the boring part from my perspective, but I wanted to show you the support for then the recommendations we're talking about. So what I'd like to do is now transition into design recommendations, and these are things like that are used commonly in marketing, things like kicking the tires, lowering the barriers to get to a particular place, having you the opportunity to try things out, like the design of how attractive a particular cell phone is or a particular component. So it's trying to use those principles to tobacco cessation to increase demand for it. Because part of the problem is that despite the fact that we have very effective treatments, the majority of smokers are not getting that treatment, and they're not doing that. So the first one is redefine the definition of success. So that's one that, when we see a patient, obviously the goal is to eventually get them to stop altogether. But if we define that as our success, every time a patient has not quit smoking, he or she is a failure. And how many of you want to be a failure? I don't want to be a failure. I don't want to be labeled as a failure. So redefining the success as, for example, I want you to think about quitting for next time and tell me what you thought. I want you to try to stop smoking and see what happens. Did you try? Good job. I mean, I was seeing a patient yesterday, and he reeked of smoking. It was the first time I was seeing him. And I said, how much do you smoke? He said, I smoke a pack a day. And I said, did you used to smoke more? He said, yeah, I used to smoke a pack and a half. Congratulations. That's wonderful. You're making progress. That means you're committed to stopping your smoking. I'm really excited about that. He sort of said like, whoa, what's going on here? Well, I said, well, that's great. Yeah, you're right. I've been thinking about quitting, and I'm so reinforcing the notions. I mean, doc, I feel bad. You're going to yell at me. I only quit for 3 days. 3 days? Wow, that's the longest you've quit in a long time. Do you realize that most people take 10 trials to do it, and you got 3 full days? How did you do that? That's amazing. See, I'm reframing success, but I'm in the process, I'm remotivating that person that when he or she is coming to me, have the tail between her legs and saying, you're going to yell at me, I didn't succeed. And when I'm saying, yes, awesome, that's great. So it's in that spirit that I want you to keep that in mind. It's a difficult process. Most people may have, even if they use the latest treatments, have a 30 to 50% chance of succeeding if you define success as quitting altogether. So redefine it and find ways to connect to maintain that process, because it's going to be a process that we're going to take multiple attempts to make it happen. You want people to be recycling and trying again, and that's one way to make it happen. So this is, remember, you have to pick 3 of these to try in your practice. So this might be one that you want to try. This is the other piece that that it's also difficult because to the extent that tobacco cessation is still having this mixed message that it's a bad habit, what did I hear on TV the other day? It's a condition. It's really a chronic disease and needs to be treated. And if you're going to give somebody treatment, you want to give the best treatment you can offer. So what's the best treatment for diabetes? Well, it's not metformin or any drug treatment. It's physical activity and dietary modification as your first line. Well, the same thing you have to articulate for patients who are smokers. If you're going to try to quit smoking, you want to try the best treatment. And the best treatment is a combination of counseling and medication. It's not, well, you might want to think about this. If you want to maximize the chances of success, and I think I've shown you the evidence, you want to be able to point to the best treatment. And they really, sure, they can try on their own, but they need to be cautious and say, you're not really using the best treatments to make it work. And we need to play, if you try to quit, consider using the best care available. And so part of it is just kind of getting clear in your mind that the proven treatments are the best care, and your patients deserve the best care for that particular component. Now, I'm guilty of this. I was part of the guideline process since the very first. This is our third iteration, and sort of the 5 A's may be something that every time you hear about tobacco cessation, people bring it up, and you sort of ask, and then if they say no, then you ask again, assess whether or not you recently quit, and assist, and then if they're ready to prevent relapse, and then you advise if they're smoking, and then you assess if they're willing to quit, and then I don't know about you, but in practice, this is not doable. So part of the effort is then to redesign the 5 A's into something that is more usable. So I'm part of a group in the American Academy of Family Physicians where we have a program called Ask and Act. 2 A's. So ask about tobacco and do something about it. Now, I'm talking a lot about what is the do that you can do, but sometimes the 5 A's are even hard to remember. Sometimes I don't keep them straight. And then you want to find ways to incorporate it into your practice. And in fact, one of the things that we are finding in terms of research is that when you directly observe people who are smokers who come to primary care offices, sometimes they're doing their A's on their own. And sometimes you deliver them explicitly as a clinician, or you do 2 or 3 at the same time. So you can't really separate them in a nice little buckets like we had it for the guidelines. So redesign the 5 A's to something that makes sense for you. And so that you can remember that you can actually and I personally there are others who say ask, advise, and refer. I like ask and act, period. Because I think that keeps you, I'm asking and then I'm going to do something about it. In my doing, maybe say, when you're ready, I'm here for you. What else can I do for you today? But you're doing something, you're telling them that you're ready for them. Or you might be handing them a card and saying, call the Ask and Act, call the hotline, and when you're ready, or put it in your pocket, put it in your wallet, and when you're ready to do it, you can bring it out. But I think if we start into too many checklists and this and that and prompts, and it just kind of gets too complicated. And tobacco cessation treatment doesn't need to be complicated. I think it's sort of the bottom line for this piece. On the other hand, you want to be ready to deliver the right treatment at the right time. We need to be familiar with counseling services. Whether you have someone in your office who is particularly interested in that and makes a connection, or whether that person is connecting them to the hotline, or even knowing what's available in your town, what's available in your community, in terms of what medications are the insurances that you mostly carried are covered in that sense. What are the local pharmacies that have the lowest price for those prescriptions? What are the community service support groups that are available? Do we have sheets or other ways of handing out the information in a way that is accessible to them? And do you have a way of contacting them or just making a note for someone to, if you do a test or you start a medication, we usually check and see if they're tolerating it okay. What are you doing when you start a smoking cessation treatment in that context? And we also need to find a way to learn how to deal with relapse. People are going to go back to smoking. What do we do then? Oh, okay, well, you tried. Sorry. I'm not touching that one, but you obviously can't do it. Well, that may be the message we're providing them unintendedly. We're saying, oh, so I'm sorry, doc, I couldn't quit smoking. I failed. Oh, okay. Well, let's talk about your diabetes. I mean, that message is saying, I agree with you. You're a failure, and there's no way you can do it. Whereas you say, oh, okay, well, you know what? Let's try it again. It looks like you're going to Vegas next week. Maybe that's not a good time to try it. When you come back, let's do it then, and see what happens. Or how the holidays are coming. How do you feel about that? You want to do it? Your birthday is coming. I mean, you want to engage in this constant conversation about it, but you also want to be ready. If they say, okay, doc, I'm ready to come. I mean, I don't know about you, but I have some patients who come over and make appointments for bogus reasons because what they really want to tell me is they quit or they want to quit and they're ready to quit. And if they're ready to quit, you want to be ready for them, providing the resources so that it doesn't take, you don't have to go on a web search looking for resources. You just say, oh, here it is, boom. Or, Mary on your way out is going to give you some sheets and that's the information you need. So getting organized in that sense when they're ready. And in terms of resources, I mentioned the www.askandact.org. That's the website for the American Academy of Family Physicians. And you can get lots of office resources there in terms of tear sheets, in terms of posters. There's really a variety of things you can offer. I don't think you have to be a member. It might be a little more expensive if you're a member. Some of it is free, but that's a place where you can get resources. And there's also a smoke-free gov that has a lot of resources from the multiple agencies in the federal government to provide resources for smoking cessation, so that's another potential resource. All right, so we're up to number 5 now. And many, many years ago when I was trained in medicine, and I was, I think, in second year or maybe first year of medical school, I was taught how to take a social history. And it was, who lives with you at home, how many kids you have, what do you work, do you smoke cigarettes? And when it came to smoking cigarettes in a social history, you said, do you smoke cigarettes? Yes. For how many years have you been smoking? And then, well, 20, okay, and you're smoking 1 pack a day, and then you said, smoker, 20 years, 20 pack years. Do you drink alcohol? Now, notice the transition. I'm taking the history. I'm asking about a disease that kills, that is responsible for more than 50% of the preventable deaths in the United States. And I'm just taking the facts. I'm losing an opportunity to address that. Do you drink alcohol? Yes. How much? Oh, about on weekends, probably, I don't know, 20 beers or whatever. And then you won't. So part of what we need to do is we need to move tobacco use and by inference, drug use and drug dependence out of the social history because, that reinforces the notion that this is a bad habit. It's a bad habit that kills you. It's a bad habit that is more insidious and more lethal than any other disease that you have. So we need to move it away from the social history. We need to really put it in the problem list. Now, how many of you list tobacco use disorder as part of your problem list? Come on, tell the truth here. Very few of you. Why don't you list that? What keeps you from listing it there? I'm curious. That was not a rhetorical question. I'm going to stop until I hear an answer. Why it's not there? Yes?
I would imagine for most people, it's just the habit, it's their own training, and they were taught to put it in social history and it's stuck.
Yeah. So I'm saying the minute you discover, I mean, if you discover someone is hypertensive, do you not put it in a social history? I mean, in the problem list? I mean, even if the visit is not related to hypertension, if they mention that I have diabetes or hypertension, you probably are going to put it in the problem list. So I suggest at any moment you find that they are tobacco users, even if they're former tobacco users, they can be in recovery. But it's there, and it's a reminder to you that that's actually happening every time. So moving it from the social history to the problem list is a major opportunity. It's a complex behavior. It requires serious and persistent attention. It's still a battle with many insurers, but I think Medicare is leading the way in there. And if we have it as part of the medical problem, I think we're going to be much more likely to address it at every opportunity. But it's also good clinical practice, because if we know they're smokers and now they're quitting, again, adjusting the medications, all kinds of implications from the tobacco are potentially related. So the number 6 point is use words as therapy in language that makes sense. Sometimes we use the anti-tobacco policies, and often that's received from a smoker as you're anti-smoker. You're attacking me personally. The word, even the term cessation, it implies that, this is a quote from John Slade, who was a pioneer in New Jersey, who said, "It is time to turn smoking cessation to be retired from active duty. In its place, the clinical activity to which it refers should be called treating tobacco dependence." Smoking cessation, again, emphasizes sort of the habit part of that. Treating tobacco dependence really emphasizes the fact that this is a chronic disease. Cessation is a throwback to the habit paradigm of tobacco use. Cessation is not a clinical activity. I'm here to suppress your bad habits. That's not my job as a clinician. My job is to treat and to facilitate the promotion of healthy behaviors. And cessation is something that the patient does, not the clinician. So I think that's an important piece to keep in mind as you're talking and thinking about that. Quitting, maybe it's also, I used quit lines earlier, but quitting may be something that also may strike fear in the heart of a smoker. But not smoking, or I'm going to help you stay one more day off cigarettes. That's kind of different. It's a different reframing. Quit line in counseling. Who wants to go? How many of you want to go to counseling? Maybe you do. I don't want to know. But the point is, counseling implies a psychiatric problem that requires major, and maybe what we're talking about is more coaching. You want somebody to help you coach through the process. So I think that's one thing that, because often patients will say, well, I don't need a psychiatrist. Why are you sending me to counseling? But it's, well, I want somebody to help you. I want someone to coach you to the process and I think that's one way to think about that. So numbers, and then often we talk about quitting smoking as a health benefit, but we also have to acknowledge the fact that for many smokers, this is a loss. This is a dear friend who's here all the time. I'm a recovering nicotine addict. I quit over 30 years ago, but I'm still addicted. I mean, I have moments when I say, ooh, that cigarette looks really good. I want to go back to it. My brain is wired for that, and if we do studies in my brain function, you can see that things will light up for nicotine. So, but I can relate to that notion that this is a friend that is there always for me. I mean, some of my friends abandon me. And so part of it is acknowledging that to your patients, and also saying, and again, it's using words of therapy, but acknowledging, I know that this is hard for you, but this is a friend that will kill you. This is a friend that is going to harm you. But it's okay that you're going through this mourning process as you're leaving this notion. And for us, showing empathy to that difficult time is an important piece of making that happen. And then also presenting tobacco intervention as a shared decision making. You know, it's not, this is what you need to do, but let's talk about that. How do you feel while you're smoking? Most smokers want to quit smoking. Most smokers want to stop smoking. See, I get into the same trap. They don't want to continue to engage, and they really want to get from under this oppression that comes from the cigarettes, the money, all the different components. So let's talk about what are we going to do about your smoking? How are we going to handle that, your tobacco dependence, and provide. It's understandable you have ambivalence, but I like smoking. Makes me feel good. Okay, tell me about the reasons why you don't like. I mean, sort of looking, exploring possibilities is also important to keep in mind. Number 7 is fit tobacco treatment into clinical team workflows. Each of you work in different settings. I don't pretend to know how they're organized. Some of you may have you and your spouse and that's it. Some of you may have staff that work for you part-time. But looking for ways, but the reality is that I don't care how big or how little your clinical practice is, you have all these people interacting with each other and working and talking and making it happen. And to the extent that you engage others in the practice to deliver brief interventions, to support what you're doing. If an MA is putting a patient in the room and saying, oh, you're still smoking? Well, here's the card. Did Dr. Jaén talk to you about the card? To the extent that you put it part of your workflow when people call you back, or if you have someone who's calling back the patient in a couple of weeks, how do you make that happen? We did a study here in San Antonio where we did an intervention in medical assistance in multiple sites. And we were intervening on diet, physical activity, tobacco, and unhealthy drinking. And the most effectiveness was in tobacco, and the MAs were very effective in getting patients to sign up to be seen in tobacco intervention clinics that we had in this particular place. So there's a role, people who work as MAs have a commitment to their patients. These are also their patients, and they want to find ways to help in any way they can. A nurse or practice manager can maintain information on tobacco medications and community service. I talked about that earlier, but it doesn't have to be all on you as a clinician. There are multiple ways to make that happen. Assessing tobacco as part of the routine vital signs is also an important piece that needs to be included. And if things are just too tight, having a flyer that can be posted in the exam room that has the information, and that it really, or one of the posters that I talked to you about may be an option. Many of you may have health information technology or electronic health records. And if you don't, you're probably thinking hard about potentially doing it in the next couple of years because there's an incentive or an opportunity to make it happen. But it's also very important that the electronic health records functions. I don't know about you. My understanding of electronic health records is they are marketed and designed to bill and to document, not necessarily to provide clinical service. But to the extent that your POS is possible, and to the extent that your electronic health record will allow it, I think it's important that you have a way of referring to the helplines. If you print a summary sheet after the visit, to have that information there. In personal health records, I think later today, we're going to hear about the sort of personal health records and accessing those. And that's also an opportunity to put smoking cessation in secure messaging about tobacco cessation, tobacco treatment in those contexts. And this is a place where we need to find ways to connect to the health record and use that as a tool to work in this direction. So tobacco treatments are often measured, and there are metrics that are used to do that. but there are a lot of opportunities besides primary care or a geriatrician's office visit in which there are opportunities to really provide treatment. Elective surgery, hemodialysis, diagnostic testing for cardiac problems, evaluation or follow-up of malignancy. So many of the people who have primary cancers may prevent a recurrence or may prevent a secondary cancer by quitting smoking, but we are not really as proactive as we could be in terms of having those options, making that happen, and then connecting it to the chronic conditions in many other ways. We have multiple touch points where that can happen, and I think that's an important thing to keep in mind as you interact with it beyond your practice to the rest of your system. Where are the places where tobacco cessation or tobacco treatments can be implemented and connected? And finally, there is a movement to really restrict, to make workplaces smoke-free and to make places smoker-free. So there are some companies that are not hiring smokers, period. There are some hospitals that have adopted a no-hire policies for smokers. So we feel that that's sort of a discrimination. What we really need to have is very strong support systems and treatment options for people who are in the workplace to make it happen. It can still be smoke-free, but I think that even the smoke-free policy and from the Guide to Community Health Preventive Services from CDC clearly shows evidence that smoke-free environments promote smoking treatment and stopping smoking, because in the process, people say, well, it's not worth my going out in the middle of the parking lot to have a cigarette. Maybe I need to look for help. In our own, I work at the Mark. It's a clinic here in San Antonio, and we have many patients who are employees of the University Health System. They come and say, now that the new policies are in place, I think I'm ready to quit. So they are effective, but we have to be careful that we're not talking about smoker-free environment, but smoke-free environments. And we need to really assist most populations with the available treatments and not shut them out of economic opportunities. Because the same people who are most likely to have high levels of tobacco use are also the folks who have less education, who have socioeconomic status that is lower, and frankly, we're really shutting them off from opportunities to move forward. It's probably very hard to see, but these are the 10 recommendations all at once. And in the design principle, include things like lowering the bar, make it accessible, make it look and feel good. And if you are interested, the reference is here. We published it this year in the American Journal of Preventive Medicine. And it's an opportunity and we expanded a little more on that. And with that, I'll stop, and I'll be happy if we have time to answer any questions. Yes?
I know we've been talking about the smoker, but we're not.
I'm not sure it's on.
Oh, well, I can talk louder.
I was going to say that we're also addressing the problem of people that are using tobacco, that
Chewing?
chewing.
Uh-huh.
There's a lot of chewing going on in Texas. And I wanted to see what you had to say about that.
Yeah. Part of the problem is that the majority of the studies have been done for smokers, not for chewers. There's no reason to believe that some of the treatments may also be effective for them, but we don't have the same level of evidence. But I think it's important. I agree with you because these are the same folks who are dying from oral cancer and multiple other problems, or even cardiac problems, and all. So yes, it's a big problem. But the guidelines sort of talks a little bit about that, but frankly, the evidence is not as direct as it is for cigarette users.
So how do you treat them?
When they come to me, I essentially use the same process. I use the counseling. I refer them to the hotline. I sort of go through that issue. In some ways, it's easier because the reward pathway for chewing is slower than when you take a drag, it's like 0.2 seconds or something like that. When you're chewing, it takes a little longer for the nicotine to get to your system. So I tend to use nicotine resin, the chewing gum as a piece. And many of you probably know, but if you are going to ask anybody to use nicotine gum, you must be very clear in teaching them how to use it. Because many patients come to me saying, oh, I tried it, but it made me sick. And part of the issue is that they are chewing it like Wrigley's, and if they do that, they get sick because there's too much nicotine release. And it's not unlike the very first time that somebody tries smoking, they feel nauseous and GI problems and all that. So I'm very clear in saying you chew it until you get a peppery taste, and then you park it in your gum until you get your next craving, and then you use it again. So I think giving that clear explanation makes a big difference.
I don't have a comment, but I would like to put in a plug for the VA system. We have our own smoking cessation. I know there are a lot of employees here, and the publicity doesn't get out. But we have a smoking cessation program that we run the first Tuesday of every month. We have a psychologist who's an addiction specialist that teaches the classes. And it's coordinated with the PharmD that's in the psychiatry clinic. And they are prescribed all of the medications and all of the nicotine replacement patches and things.
This is Dr. Peterson. Who's the psychologist?
Dr. Donahoe.
Oh, okay.
Yeah. So if anybody's interested, we put out flyers, but if you need information, you can call us on 1C, and we'll give you the flyers for your patients. Thank you.
Great. And since you're talking about plugs, Dr. Peterson and I have a book coming out directed to psychologists and clinicians in terms of how to do tobacco cessation, and that'll be coming out sometime this year. Yes.
With the hospital being a smoke-free area, how realistic or effective is it to try and work with your patient while he's there, like from a heart attack or an accident, extended or surgery? You know that they're gonna be there, and they are without smoking for 10, 30 days. Who knows that period of time?
So I think it's very important that a smoke-free implementation pay attention to things like that. So in our hospital, part of what happens is there is a protocol for anyone who's a smoker, and they look for contraindications for different therapies, and most of them end up having a patch placed on them. And even if you have a cardiac problem, I think that a 14 milligram patch is relatively safe. And I think that's the piece, because I mean, it's not only the smoker, but it's also the disruption that they bring from being in withdrawal. And we're helping the nurses because frankly, they're gonna drive them nuts. But it's also good therapy, and I think that I have several patients that said, I never thought I would be able to stop smoking, and in fact, I was in the hospital, and that's when I did it, and hey, I can do this. So I think it's an opportunity also to try it out. All right, well, thank you.
Buenas noches, iniciamos con noticias de última hora. Les saluda Brenda Jiménez.
Y Jorge Núñez. Pues ¿estará usted de acuerdo que nuestra cultura nos enseña a respetar a las personas de la tercera edad? Pero no siempre es fácil cuidarlos durante la etapa de la vejez.
Por esa razón, líderes en el campo médico se reunieron bajo el mismo techo el día de hoy y Anabel Monge nos explica más.
Así es, Jorge Brenda. Según los expertos, el cuidado para las personas de la tercera edad puede convertirse aún más difícil si ellos viven con algún problema físico o quizá alguna enfermedad. Para la mayoría de las culturas, los abuelos son preciados miembros de la familia, pero a la vez todos sabemos que el envejecer no siempre es fácil. Esta etapa puede llegar a ser más frustrante cuando la persona de la tercera edad vive con problemas físicos o demencia.
Comunicando con una persona o diciéndole que necesita ayuda o que quiere comer, por ejemplo, puede ser algo bien difícil para una persona que tiene la enfermedad.
Los expertos indican que los problemas físicos y el dolor crónico disminuyen las capacidades y aumentan el estrés y la ansiedad, no solo para el paciente, sino también para la persona que le está prestando cuidado médico o emocional.
Y es muy importante que las personas que los cuidan, que se educan sobre la enfermedad y qué pueden hacer.
Con la meta de educar a la comunidad y en especial a los integrantes del campo médico, hoy viernes en San Antonio se realizó un foro informativo donde mediante discusiones detalladas se habló sobre las diferentes enfermedades que afectan a las personas de la tercera edad y cómo sobrellevarlas.
Es muy importante educarnos, saber qué podemos hacer, saber que conectamos con la Asociación de Alzheimer's, en conectarnos con tipos, con grupos de apoyo.
Y bueno, aunque este foro informativo se realizó aquí en el centro de la ciudad de San Antonio, la sesión contó con la presencia de varios expertos de a través de toda la nación. Anabel Monge, Noticias 41,